Hey everybody, this is our voiceover PowerPoint for Module 6, Part 2, a continuation of problems of oxygenation and ventilation for Nursing 353. So I wanted to briefly touch on pleural effusion. What I like about this picture is it shows the fluid down here, and notice how they are using like a needle and they're pulling that fluid off, and it depends on how much, how that would actually look. And I really like how it shows the lung kind of smushed up, or as it says here, compressed. So we'll talk a little bit about the signs and symptoms in the next slide. So a pleural effusion is an abnormal amount of fluid in the pleural space. Normal amount of fluid in that pleural space is only 10 to 20 milliliters, so less than an ounce. It is not a sign of disease specifically. It tells us that there's something else going on. So there are two types of pleural effusion, transudative, and the types depend on the protein content. So transudative is non-inflammatory disease, and that tends to be a little bit more clear. And then exudative is inflammatory. And we talked about this a little bit in class the other day, but an empyema is where you have purulent fluid in that pleural space, kind of on the outer part of the lung. So treatment for a pleural effusion, if it's just fluid, we're going to usually drain that. If they do have an empyema or some sort of infection, we would anticipate them to be on antibiotics. And then the signs and symptoms of a pleural effusion. The patient will often be short of breath. They'll have a dry cough. They may have sharp chest pain or that pleuritic chest pain that we talked about the other day. Decreased chest movement, dullness, decreased breath sounds, especially over that area on that affected side. And we'll usually do a chest x-ray and a CT to locate and where the pleural effusion is and get an anticipated amount for the volume. And again, we talked about that empyema. Additional symptoms with an empyema would be a fever, night sweats, that cough again, and weight loss. And as I mentioned in class, pleural effusions sometimes happen after pneumonia, or if you have one, it can actually cause pneumonia because of that compressed lung. So the care for somebody with a pleural effusion is going to treat the underlying cause. So some of the things that can cause a pleural effusion can be cancer, it can be heart failure, or it could be like the pneumonia that I talked about. So depending on what the cause is, it will depend on those additional measures that we do for it. Now, one of the things that we typically do is a thoracentesis, especially if they have a large volume. And that's where they do a procedure to remove fluid, or if there's air in there from around the lungs. They put a needle into the space, into the chest wall, and then they actually drain that out. They might, depending on how much they get out, they might hook them up to a chest tube when they're doing that drainage, and that is talked about in a future class. And if somebody has an air leak or they keep getting problems with their lung, they might do what's called a chemical pleurodesis. And a chemical pleurodesis is where we instill something into that pleural space. Frequently it is talc, or sometimes it is antibiotic. And once the healthcare provider inserts that in there, your job as the nurse is to have the patient turn. So they'll be on the right side, then they'll be on their back, and then they'll be on their left side. And you're really trying to like kind of shake and bake that talc or that antibiotic to get it to everywhere it needs to be. And the healthcare provider will usually write the orders of how frequently they want you to turn and how long they want them to be on that particular side. Now in this picture, it is showing a thoracentesis. So you'll see that they have inserted that. They're going to drain that. Again, I like how it's showing that compressed lung. They will generally not drain more than 1,000 to 1,200 milliliters at one time. And generally when they're doing the thoracentesis, the patient will cough. And once they start coughing, it lets the healthcare provider know that they probably need to stop pulling that. Now, one of the big complications with thoracentesis is you have a risk for a pneumothorax. So before and after the procedure, obviously this is a consented procedure. It can be done right at the bedside. We're going to do vital signs, listen to our lungs prior to, and then again right afterwards. They'll also do a portable chest x-ray if it's done in the room to make sure that they don't have a collapsed lung. One of the reasons we monitor for hypotension is when we pull that fluid off, depending on what the cause is, fluid may go back there. And then as that fluid is going back to that pleural space, it's pulling it from the vascular bed, which can cause that hypotension. So again, we're going to continue to monitor those vital signs, pulse ox, and signs of respiratory distress afterwards. And one of the other things is that they will frequently send this fluid off to the lab. So they might send it for cultures or pathology report to check for cancer cells. And so those are some of the things that you'll help the healthcare provider with as far as for labeling those labs. Now notice the positioning for the thoracentesis in this image. That is probably the most common positioning that I've done when I've assisted with a thoracentesis. So the patient's going to be sitting on the side of the bed. They are going to be leaning over that bedside table, and the healthcare provider doing the thoracentesis is going to be behind the patient. Frequently, I help kind of behind the patient as I'm helping them draw up their lidocaine and those other things, and then I move toward in front of the patient to help give them support during it. Another way that you can position the patient if they cannot sit on the side of the bed is that you would have them lie in bed with the affected side up so that the healthcare provider can get to that. And then the affected arm would go over the head of the bed, over their head, not head of the bed, over their head. Now, I know we've talked about atelectasis multiple times throughout this class. I love this picture though because it shows you what normal alveoli look like versus those collapsed alveoli. And so we know that when we first listen, we'll hear decreased or absent breath sounds, and then we may actually hear that crackling noise as they take a deep breath and those collapsed alveoli are opening. As we've talked about before, patients who are at risk of this are going to be post-op patients, specifically abdominal or chest surgery patients, or patients who are not ambulatory very much. And of course, as we've talked about multiple times, our prevention and treatment is going to be deep breathing exercises, incentive spirometer, and early ambulation. So next we're going to be talking about tuberculosis. And with tuberculosis, it is an infection caused by a Mycobacterium tuberculosis. The lungs are most commonly affected, but it can affect all kinds of parts of the body. 1/3 of the world's population does have TB. The prevalence in the United States was decreasing. I'm not sure with the number of immigrants that we're getting if that has increasing since then. Risk factors, and this is one of those things I want you to know, risk factors for getting tuberculosis: homeless, residents of inner city neighborhoods, foreign-born persons, living or working in institutions such as prisons, nursing homes, shelters, and hospitals, IV drug users, overcrowded living conditions, less than optimal sanitation, poverty, poor access to health care, or patients who are immunosuppression such as HIV, cancer, or long-term corticosteroids. And so when you look at these risk factors, one of the things that you notice are those things that these people are generally in crowded conditions. And so that crowded conditions, by being so close to each other, is one of the things that increases the risk for the transmission of tuberculosis. Tuberculosis pathway, or pathophysiology. It is a gram-positive aerobic acid-fast bacillus, AFB, and one of the things we'll do is actually send sputum off testing for that acid-fast bacillus. It is spread via airborne droplets, and what's interesting is those airborne droplets can be suspended in the air for minutes to hours, which is why we do the isolation types that we do. Transmission does require close, frequent, or prolonged exposure. It is not spread by touching, sharing food utensils, kissing, or other physical contact. The number of concentration, length of time for exposure, and immunity influences the transmission. Once it is inhaled, droplets lodge into the bronchioles and the alveoli. Local inflammatory reactions occur, so a Gone lesion or focus represents a calcified TB granuloma, and that indicates primary TB infection. Now, granulomas is a defense mechanism to wall off and prevent spread. So sometimes somebody will have this, but they have this granuloma that keeps them from not being active TB. So only 5 to 10% of people with dormant TB will develop active TB, and that may take months or years. Now, M. tuberculosis is aerophilic, meaning it loves oxygen, and that's why it has that affinity for the lungs. Infection can spread via the lymphatic and grow into other organs such as the cerebral cortex, the spine, the epiphyses of the bone, the adrenal glands, liver, kidneys, and lymph nodes. Latent TB infection. So let's talk about this. It is somebody who is infected, meaning they will have a positive tuberculin skin test, but they are not active disease. Their chest x-ray will be normal and their sputum smear will be negative. They are asymptomatic, they don't feel sick, they are not infectious and cannot transmit that to anybody else. But the problem is they may develop TB later, especially if there's immunosuppression, diabetes as they age, pregnancy, stress, or any chronic diseases. And that's why it's so important to treat somebody with latent TB to prevent them from going into active TB. Active TB usually takes 2 to 3 weeks to develop symptoms. However, it can happen more suddenly. The patient does usually feel sick. They are able to spread TB to others. They will have a positive tuberculin skin test. They may have an abnormal chest x-ray or a positive sputum smear, and they need treatment for active TB. And the signs and symptoms are going to be that initial dry cough that eventually becomes productive and it lasts over 3 weeks. Other symptoms include pain in the chest, fatigue, malaise, weakness, weight loss secondary to that no appetite, low-grade fever, night sweats, chills, and crackles. Late symptoms are dyspnea and hemoptysis. Now, just to note, if somebody does get those more sudden symptoms, their symptoms tend to be a little bit different as far as they'll have a more high fever and just be sicker, and they can actually go into respiratory failure, but that's not as common. Unfortunately, we are seeing multi-drug resistant tuberculosis, and this is resistant when TB is resistant to 2 of the most potent first-line anti-TB medications, isoniazid and rifampin. And there are several causes for this resistance. Part of it is incorrect prescribing, lack of public health case management to ensure that people are staying compliant, which is part of the next one, that non-adherence, although I prefer the word non-adherent over non-compliant, and then lack of funding for education and prevention. So there are a couple different tuberculin diagnostic tests. The one that you're probably the most familiar with is the tuberculin skin test, also known as the MAN2. And if we actually inject that 0.1 milliliters into that ventral forearm, as you can see in that picture. And then it's also considered a 2-step test, meaning that we inject it and then we have to assess it 48 to 72 hours afterwards. Now, a positive tuberculin skin test is if we have greater than 15 millimeters induration in our low-risk individuals, a greater than 10 millimeter induration in high-risk individuals, or a greater than or equal to 5 millimeter induration for immunocompromised, such as HIV. Now, there are false positive and false negatives with the tuberculin skin test, and that's why they do have some blood tests. Blood test, the interferon INF gamma detects the gamma released from T cells in response to the M. tuberculosis. There are some that are called the quantiferon TB Gold in tube and the T-spot TB test. The advantage is you get results quickly. The patient only has to come one time, but it is more costly than the tuberculin skin test. Now again, this slide is very important. knowing the induration for the population is really important. So notice that we're not just looking at the redness. In order for it to be a positive tuberculin skin test, there has to be induration, meaning a hard raised area. And again, that greater than or equal to 5 is going to be HIV patient, somebody with recent contact with an active TB patient, nodular or fibrotic changes on the chest x-ray, organ transplant, greater than 10 millimeters, equal to, or greater than 10 millimeters is recent arrivals from high prevalence countries, IV drug users, resident or employees of high-risk congregate settings such as jails or nursing homes, people who work in the lab with mycobacterial, comorbid conditions, children less than 4, and infants and children and adolescents exposed to high-risk categories. And then for healthy individuals, it's going to be that greater or equal to 15 millimeters. Now, additional tuberculin diagnostic tests are a chest x-ray. A chest x-ray cannot make a diagnosis just by an x-ray. It can appear normal in a patient with TB. The number one gold standard for identifying TB is the culture, so that's sputum culture. We do have to get 3 consecutive sputum samples anywhere from 8 to 24-hour intervals, and one of those has to be an early morning specimen. They'll send that sputum off they'll stain it looking for the AFB. A definitive diagnosis is when we have that mycobacterial growth, and that can take up to 6 weeks. We can also collect samples from mothers suspected with TB sites. Tuberculosis treatment, most patients are treated as outpatients. These patients are going to be on these medications for months, and so we're not going to keep people in the hospital for that. They are infectious for the first 2 weeks starting treatment if the sputum is positive, and they are going to need to restrict visitors and limit public exposure. Hand hygiene and oral hygiene are going to be important, and aggressive drug therapy used to treat active disease and prevent TB resistance, we have to monitor that adherence. So drug therapy for tuberculosis varies depending on the phase. In active TB, there are 2 phases of treatment. In the initial 8 weeks to 3 months, there are 4 medications below that they might get. And then continuation is 18 weeks where they get 2 drugs, isoniazid and rifampin. Now, the 4 initial drug medications, isoniazid is known for potentially causing hepatitis, so we would teach that patient to not drink and be careful with acetaminophen. Rifampin also has a risk for hepatitis, and what is really notable about that is that the body fluids can turn orange, and those orange body fluids can actually stain their contacts, and their urine will be orange, but that goes away once they get off of the medication. Pyrazinamide also can cause hepatitis, so we're going to be monitoring for those liver function tests for all of those. And ethambutol can cause ocular toxicity, meaning that we'll have some, which is where we're going to have vision changes. Patients need to be taught about adverse side effects and when to seek medical attention. Non-viral hepatitis is a major side effect for 3 of the 4 first-line medications, and liver function tests should be monitored, as I mentioned earlier. There are alternatives available for patients who develop a toxic reaction to the primary medications. Now, patients with latent tuberculosis infection again need to take medications to prevent them from going into active TB later on. They are often treated with isoniazid for 6 to 9 months. HIV patients and those with fibrotic lesions on chest x-ray should take the isoniazid for 9 months. There is an alternative where they do a 3-month regimen of isoniazid or rifampicin or 4 months of rifampin. And that just helps to decrease the amount of time they have to be on something, which is going to increase our adherence. So with multi-drug resistant tuberculosis, the sensitivity test determines the medications used. In the initial phase, 5 medications are used for at least 6 months, 2 first-line medications with a fluoroquinolone, which is a type of antibiotic, an injectable antibiotic, and 1 or more second-line. Continuation is going to include 4 medications for 18 to 24 months. There are 2 new drugs for combination therapy, bedaquiline and delamanid. Direct observation therapy helps to decrease our non-adherence because non-adherence is a major factor in multi-drug resistant tuberculosis and our treatment failures. So they're actually going to provide the medication and watch the patients swallow it. It is expensive, but preferred public health strategy to ensure adherence. Unfortunately, we don't have a lot of public health doing this, and getting the patient to go to the public health can be a problem. And it can be given by a public health nurse at any clinic site. Now, one thing to note that's important is the BCG vaccine, Bacillus calmette-guerin. It is a live attenuated strain of the Mycobacterium bovis. It is given to infants in parts of the world with high prevalence of tuberculosis. In the United States, it's not recommended due to low risk of infection, except for select individuals. The BCG vaccine can result in a false positive tuberculin skin test. Tuberculosis health promotion. Ultimately, we want to eradicate TB worldwide. Selective screening programs to detect DP in high-risk groups is one of the ways we can help with that. We need to make sure that we are treating latent TB infections to decrease the carriers. If somebody has a positive tuberculin skin test result, we should have them do a chest x-ray. And TB is reportable to the public health department to help identify contracts and risk to the community. We need to address social determinants of TB, the decrease to healthcare access and improve education and the poverty, all those factors that are affecting TB. So when we have somebody who has tuberculosis in the hospital, they're going to be in airborne isolation, which means they need to be in a single room where there is negative airflow. So that's going to help get rid of some of those air exchanges. Healthcare workers need to wear high efficiency particulate or those HEPA masks, and those have to be fit tested. You can also wear the capper or papper, depending on the one that kind of makes you look like a stormtrooper. And then immediate medical workup and chest x-ray, sputum smear, and culture needs to be done, and checking for appropriate drug therapy. We need to teach the patient to prevent the spreads. We need to teach them to cover their nose and mouth with tissue when coughing, sneezing, or producing sputum, and dispose in the trash or flush it in the toilet. Hand washing after handling sputum-soiled tissues. Patient wears a face mask if outside of the negative pressure room, and we need to identify and screen the close contacts. So considering ambulatory care, patients are going to go home even if they have positive cultures. They will get monthly sputum cultures, and once they've had 2 consecutive negative cultures, they are no longer considered infectious. We're going to want to teach the patient to minimize exposure to others. We're going to teach them adherence and to their caregivers, help to give them strategies to make sure they're taking their medications appropriately. We will notify the health department, and the public health nurse will follow up, and then they might use that DOT therapy, directly observed therapy. We want to teach them symptoms of recurrence and factors that could reactivate TB, and we want to really encourage smoking cessation.